Welcome, everyone. Welcome to Stanford Medicine's virtual town hall on COVID-19, episode number 6. Today, our theme is towards restoration and recovery. My name is Andra Blomkalt. I'm the chair of emergency medicine. Today, we're joined by Stanford Medicine leadership and an esteemed group of panelists. Ron, why don't we start introductions?
Good morning. I'm Ron Pearl, chair of the Department of Anesthesiology, Perioperative and Pain Medicine.
And I'm Bonnie Maldonado, and I'm a professor of pediatrics and epidemiology and population health.
I'm Norman Risk. I'm the chief medical officer of the adult system and senior associate dean for clinical affairs.
I'm Joseph Wu, chair of the Department of Cardiothoracic Surgery.
Mary Hahn, chair of the Department of Surgery.
And I'm Denny Lund, the chief medical officer of Lucile Packard Children's Hospital.
Hey, thank you. And at this point, we'll turn it over to our Stanford Medicine leadership to let us know what is top of mind this week. Lloyd.
Thank you very much, Andra. Good morning, everyone. 1 month ago today, the 7 Bay Area counties put into place a shelter-in-place order with the associated social distancing that goes with that order. Each of our lives has been radically transformed by the effects of that social distancing. But it's important that we stay the course because it's been the shelter in place and the social distancing that has led to a dramatic decline, or at least a dramatic attenuation in the number of cases we were expected to see of patients infected with COVID-19. As a result, our healthcare delivery system has been able to do what we do the very best, and that is to deliver outstanding care to people with COVID-19 and to others. And as Andra indicated, today we can begin the discussion of how to restore and bring programs back online that we temporarily had to put on hold while we were preparing for what could have been a dramatic surge in the number of patients infected with COVID-19. Also, it's important today to recognize and to thank our leaders of the federal government for bringing about an unparalleled amount of stimulus funds to help in combating the COVID-19 infection, as well as to do research and to promote innovation in the treatments and the preventions that are going to ultimately enable us to defeat this virus. And I know that our Stanford faculty and staff are going to take advantage of those research grants and other innovation funds. Finally, we've put together 2 task forces to address the issues associated with bringing programs and surgical procedures back online. The first of these is a task force devoted to procedural activity. We canceled elective surgeries at the time that we went into shelter in place, and yet the need for healthcare has not gone away, and we want to make sure, as Paul and David will indicate in a moment, we want to make sure that everyone knows that we're here to provide that health care. And the second task force that we've established is focused on the ambulatory transformation. As you've heard from David and Paul in previous town halls, we've dramatically increased the number of virtual visits that we're doing. Now, we want to make sure that as we move out of, in the future, the social distancing and the other guidelines that have led to the need for these virtual visits or the acute need for the virtual visits, we want to make sure that we're still preserving the beneficial effects of those visits. And that's going to be the area of focus for the Ambulatory Transformation Task Force. Thank you again for joining us, and I want to turn it over to David now. David?
Great, thanks, Lloyd. As we think about, I love what Lloyd shared about being sequestered in place. I also want to thank your families, because I know it's difficult probably for many of you to have you go to work and sometimes your family or roommates are still sequestered at home, but we appreciate the fact that they are staying home and making sure this virus doesn't get spread. As I think about our emergency department, or even think about bringing things back online, we're very cautious about that because we want to make sure, the reason we put this into place is to make sure that our staff, that our faculty, that our patients were kept safe. It also allowed us to create additional capacity, of which we saw was critical as we thought of a surge in some of the things that might be coming down the pike, from what we see in other communities. Now, as we see in the community around us, however, and you'll see a slide that we'll show here, there's a real challenge because people are actually avoiding sometimes the care that they need, especially at critical times. As you can see from the slide, and even in the New York Times, it's stating that, in fact, people are avoiding the emergency room because of a fear and anxiety that it may not be safe. They're also avoiding care that can be critical. Now, we're seeing that even in New York, with things being down 50%, in our own ED here, it's almost down 40 to 50%. So we know that people are making decisions about when to seek care based on the way that they feel, sometimes whether it's a safe environment. We want to make sure that our community knows that we do have a safe environment here. As we look at some of our marketing and initiatives to share with the community, how can we share with them that we are a safe environment for them to be able to come back to and get that care? Because if they do delay that and it becomes to the point where it is more critical, that could be an outward outcome for our community. We want to make sure they feel that level of safety. Now, how do we know it's safe? We have put into place, and you've heard over many of the town halls that we've had PPE that we have been able to acquire. We have trained the staff on how to use that. At the same time, we are able to assess quickly if our staff are having challenges with the virus or getting sick themselves, to make sure through occupational health we're doing the things to keep them in the right environment to be safe for our communities. So as we think about inviting individuals back in for the needed care and not delaying those necessary resources, we want to make sure that they feel comfortable about that. And we know that we've provided a safe environment for them to do that. So we're being cautious, but at the same time, we want to make sure we invite them back in. And you're going to see the marketing efforts that we're able to push out to help assess that. We've been here for a while. We have been a part of our community. We have been a resource, something that they have trusted in, and they know that we're here irregardless of the challenges in our community for the services that they need. And we want to continue to make sure that we have that level of confidence from our community that we're here there for them. Let me turn the time over to Paul.
Thank you, David. Good morning and welcome back. For the past 6 weeks, we've been sharing with you the latest information that we have about this virus, and more importantly, the impact that it's having on us here at Stanford Medicine. When you look at the themes that we've used to talk about this over the past 6 weeks, we've looked at this through the lenses of science, people, and business. For the first 5 of these sessions, we've appropriately weighted more heavily the discussions around science and people. Science, because as we learn more about this virus, we become smarter in terms of how to attack it. People, because we want to make sure that you remain safe and that we do all that we can do to make sure that you're available to take care of those who need us most. As Lloyd mentioned earlier, at the beginning of this crisis, we were asked to stand down those necessary but non-urgent services that we provide. That was a significant ask, but we answered that call. In answering that call, we turned off, as David was just saying, anywhere from 30 to 60% of our business. On any given day, that represents literally millions of dollars of lost revenue that we no longer have as a result of that appropriate decision that was made to make sure we're available for that surge that we were anticipating that now looks like it's not going to be as severe as was originally anticipated. So now as we move forward, we are working with the leadership at the School of Medicine and between the 2 hospitals. We're working on countermeasures in terms of what we can do to go forward to safely resume operations in terms of beginning those procedures that are safe to do so, and you're going to hear more about that from our panelists today. We'd also like to take this opportunity to thank a group of committed volunteers in the community who've been working with Lloyd, David, and I in terms of service on our boards of directors. This is a group of industry and community leaders who stay focused with us tirelessly on our mission and make sure that we're good stewards of the resources that we have to carry out that mission. With that, I turn it back over to Andra.
Thank you. So similar to previous town halls, we have some submitted questions, and thank you to those of you who've pre-submitted those questions online. The first question goes to Joe. When will we resume elective surgeries? And we know that already UCSF has started some.
Thank you, Andra. We have heard through social media outlets and other avenues that some institutions are contemplating the reinitiation of elective surgery. However, at Stanford, we've taken a more measured approach, and with the support of our dean and our CEOs, we are examining the Federal Center for Medicare and Medicaid Services guidelines and recommendations on levels of procedures to consider reinitiating. We have, up to this point, of course, taken care of all of the patients with emergent and urgent conditions, but we have been very thoughtful about those with less urgent conditions and those with more elective conditions. And so we hope to have the ability to reinitiate the care of those types of patients very, very soon, keeping in mind, of course, the consideration of the safety of the patients, the safety of the healthcare workers, the conservation of PPE, and retaining the ability to manage a COVID surge if indeed that ever comes. In addition, there is a bidirectional component to all of this. The physicians, surgeons, and staff at Stanford are ready and very willing to care for the patients. However, many of the patients have significant concerns about coming to the hospital. There are worries about infection and other concerns. And on our service, for example, we have several patients who have encountered devastating complications of conditions that under normal circumstances would have easily been addressed at a much earlier time point. So it's of vital importance that we communicate to the physicians and the healthcare providers in the community, as well as the patients, that Stanford is ready to care for these patients, and that it's a very safe and extremely well-equipped environment to receive their care.
Thank you. Denny, how does Stanford Children's Health plan on resuming services, and how might that look different than from SHC?
Thank you, Andra. First of all, I want to reiterate what Dr. Wu has said about urgent and emergent cases. There's very little done in an academic medical center that's truly elective. We have worked very hard to be able to handle our true emergencies, but our urgent cases have been delayed, and they've been delayed really based on their degree of urgency. But what we know about these conditions is that they get worse with time, and particularly in children, as we wait longer to do urgent cases or testing, the urgency gets higher, and so we have to be paying attention to that. So what we've done at Stanford Children's is to really get a list of all of the patients who've been delayed or scheduled cases were canceled because of this crisis. We've been in touch with those patients, and our providers are triaging those cases as to the urgency so that we can get to them as soon as possible. Now, the one fundamental difference between Packard and the adult hospital, besides the age of our patients, is that the adult hospital has many more ambulatory options for caring for some of these problems, particularly imaging sites and ambulatory operating room sites. At Packard, we tend to do pretty much everything in the main hospital. So we're going to have to adapt our procedures and our policies and our thinking around how safe it is to bring our patients into the main hospital as opposed to dispersing some of the care to ambulatory sites.
Okay, thank you. Ron, we know that many procedures have been canceled. When do we anticipate that the operating rooms will go live, and how will we prioritize patients to get those cases?
Thank you, Andra. First, in terms of resuming elective cases, I view it in terms of in the context of our three major responsibilities, namely to our patients, our healthcare providers, and to the community, and that our decisions should be based upon scientific evidence and the input of experts, national leaders such as Dr. Maldonado on COVID-19. In terms of our responsibility to our patients, we need to be sure that, in fact, we can do elective surgery safely and that we can make the patients feel safe. It requires that we know that the incidence of COVID-19 is low in the community, and that's low in our healthcare providers, that we are having negligible patient to provider and provider to patient transmission, that we are confident that we will not see a surge in COVID-19 in the community, that we have adequate PPE to protect both our patients and our providers, and that we have adequate testing for what we believe are the needs to safely do more surgery than we're doing right now. The term elective surgery, I think, is not often well understood. I would go back to this context of wanting to do what is best for our patients. And the reality is that although we have not done some cases that we otherwise would have done, often that has resulted in what's not best for the patient. In other words, continued pain, disability, not being able to work, or potentially progression of disease. And so in terms of our responsibility to patients, we do want to start being able to offer surgery to a larger number. This will follow the tiers which have been established by CMS, as Joe talked about, and by the American College of Surgeons. And we will first prioritize which patients will benefit most from surgery, which ones will have least impact potentially on the healthcare system. And as we monitor our success with that, we will be able, assuming we get approval from regulatory authorities, to safely start doing elective cases and then begin to work through the backlog of cases we have not been able to do during this time.
Thank you, Ron. I think that's all really very reassuring news, because not only have people been having to put their lives on hold, they've also been having to put their procedures and their necessary surgeries on hold. So I'm really reassured to hear that all good news. Mary, what does a phased reintroduction look like for you?
Thanks, Andra. So it's hard to believe that it's just about 6 weeks ago that our hospital was full. We were at capacity. Our operating rooms were running at full speed. And we, in response and in conjunction with our county leaders, abruptly interrupted the care of a large number of our patients who were scheduled for procedures that were going to have dramatic improvement for their quality of life, but could be delayed so that we could create capacity to care for the COVID-19 pandemic, for the potential surge that we had seen in other countries had totally overwhelmed their healthcare delivery systems. And so we needed to create that excess capacity within our hospital to deal with the surge. Now, fortunately, because of the good wisdom of our county and our state leaders and the shelter-in-place orders, we've not had to experience that surge here in California. And we have plenty of capacity to care not only for COVID patients, but for those patients who we interrupted their care. So how do we phase that care back in? Just like my colleagues have said, we're tiering them based on the urgency of their procedures, the burden of their symptoms, how much longer can we delay their care? We're also looking at each individual patient and saying, is it safe for them to leave their shelter in place and potentially come to a pre-op clinic visit, get tested for COVID, make sure that they're clear, and come into the healthcare system to have their needed surgical intervention. So we're looking at both the risk to the patient, the risk to healthcare workers, and we've been very thoughtful in our staged approach in terms of how we protect our healthcare workers, what we do to ensure that we would not contribute to the spread of COVID by providing care to the non-COVID patients. So we have a very thoughtful plan, and I think we have the capacity to do both in a way that's safe for all the parties.
Thank you. Norm, what sort of safety precautions do we plan to implement, and how does that look like for PEE?
Thanks, Andrea. Probably as many people know, we have already instituted extensive screening for visitors to our hospital and patients. So everyone, staff, patients, visitors, that enters the hospital is screened at the front door with a symptom score, plus also taking their temperature. We've instituted universal masking, and we've prohibited visitors from coming into the hospital. The next phase really is much more comprehensive. It will involve conducting studies about the prevalence of infection in the community so that we know what the risks of visitors and patients are. And then we will test all of our healthcare workers. We'll provide that to them so that we can identify who might be an asymptomatic carrier, and so we can isolate them. We really intend to create a safer environment than the external, untested world. We already have some data that supports that we're achieving some of those goals. We've tested 2,700 symptomatic healthcare workers that had an illness that could be confused with coronavirus, and only 3% actually had it. This contrasts with the external world, where we've done 12,000 tests of symptomatic patients, where 8% had it. As time goes on, we will be able to identify anyone in our environment who's shedding the virus and separate it from the environment. On the PPE question, we keep daily a spreadsheet on all of our supplies down to the size and our burn rates so that we know what access we have to protective gear. The good news is that we don't make our policies based on our supply. We make our policies based on what's safe and infection control, and we have adequate PPE to provide that so that we can meet the guidelines that we think are evidence-based. In the end, of course, safety is the balance between minimizing the risk of infection, which we're proceeding to do, and the risk of deferring treatment of progressive disorders, as everyone's been talking about.
Great. Thank you, Norm. The next question is for the emergency department. Now that the imminent threat of a COVID surge seems less imminent, are you ready to see both COVID and non-COVID patients? I will say that a very enthusiastic and cautious, absolutely yes. I think we can be really reassured that so few healthcare workers, thanks to the attention to safety and appropriate PPE, actually contracted the disease. I also feel as though in the emergency department that both patients are safe, whether they're COVID or non-COVID. And we don't want people to stay at home and keep their chronic diseases or the acute manifestations of their chronic diseases not being cared for. So we welcome people back to the emergency department. The next question is for Bonnie. What is the Stanford serologic test used for, and what exactly does it tell us?
Thank you, Andra. So as many of you know, we are very fortunate not only to have one of the first FDA-reviewed, CLIA-approved PCR tests to look for the virus, but our faculty and staff here were able to develop a very accurate test for antibodies to SARS-CoV-2. This test is available in the diagnostic virology lab, and that has been tested against a whole panel of other viruses to be sure that the results are accurate. And if you have a positive test, it really does indicate that you have had exposure to this virus since the beginning of this epidemic, which we think in the Bay Area probably started in late February. So that is really, unfortunately, the only thing we can say for certain about this test and the tests all around the country. In fact, we're confident that our test is probably more accurate than most of the tests that you will see online at many other institutions. So what we're trying to find out are a number of other things that would be very helpful for us to know about these antibodies. And the first one is, does that mean that I, as an infected antibody positive person, would I be protected against future infection? We don't know the answer to that. So it's possible that the antibodies could just reflect evidence of infection but no protection. It could be that I would be protected against disease but still be infected and then could be infectious to others. And then finally, we don't know that if this antibody is protective, will it stick around, or will it last long enough through potentially another season or for a number of years? So those are questions that we're trying to answer right now so that we can understand exactly what it means when somebody has an antibody test and how safe they can feel they are with those antibodies.
Thank you, Bonnie. I wanted to add, you mentioned additional tests that seem to be available, or we hear about them on TV or on the internet. Would you encourage our community to go out and purchase those to learn about their COVID disease state?
You know, I think people have to make their own judgment about that. Read the literature on the websites, but be very, very careful, because we've actually taken in a number of those kits ourselves. They've been given to us, and our laboratory has tested them. And there is a good chance that people will see that they may actually look like they're tested as antibody positive when in fact they may not be, or antibody negative when in fact they may not be. So many of the tests that are out there, again, have not been reviewed by the FDA, and it's not clear what the test results might actually mean.
Okay, thank you so much, Bonnie. So now we're going to go to the live questions. The first question goes to Ron. A lot of patients are still afraid to come to Stanford because they're concerned about being exposed to COVID-19. What are we doing to assure them that they're safe here?
So I think it means having them develop first trust in Stanford, and then second, for us to be confident that in fact they are safe here. Building trust in Stanford means having them understand that our motive for having them come to Stanford and have care here is to improve their health. It's not a business motive, et cetera, and that our decision for that being safe is based again on good scientific evidence in terms of the low incidence of COVID, that the precautions we are taking at Stanford are effective in preventing both transmission to them and transmission from them. I think having increased testing is certainly going to help. Explaining the precautions that we are taking will help. For patients having elective surgery, again, testing them to be sure that they are not infected beforehand will be of value. Some of the tests Stanford is doing using the antibody Dr. Maldonado talked about will also be beneficial in demonstrating, again, that coming to Stanford is safe for these patients. They will not acquire infection, nor will they transmit infection while they are here.
Great, thank you so much. The next question goes to Joe. How confident are you that we can quickly ramp up volumes at our hospitals?
We have the staff, we have the physicians and surgeons, we have the capacity. I think we can ramp this up very, very quickly.
Excellent. Mary, can you tell us a little bit about what sort of things are being employed in terms of testing, both for patients and providers, as we phase into this new realm?
Sure, of course. So through our testing centers, we've set up preoperative testing for anybody who is coming in from home for surgery. So they will go to one of our testing centers, get swabbed, and we'll know their COVID status before they come into the hospital. And so that has been one of the strategies that we've used to ensure that it's safe when patients come in, and we know that they're not exposing healthcare workers or other patients, and we know that it's safe for them as well.
Thank you so much. Norm, the governor of California has signaled that he is planning to gradually reopen the economy and lift the shelter-in-place orders. How are you planning to work with local and state officials to ensure we are in step with this evolving guidance?
So we have a lot of connectivity to regional and statewide forums in which decisions are being made about the regulations and the guidance. For example, Christina Kong, who runs our clinical lab for COVID testing, is on Governor Newsom's newly announced testing task force. Nigam Shah, another of our faculty members, has been sharing all of his epidemiologic predictions with the county of Santa Clara, which I think has been beneficial to the whole county. There are other connections like Nirav Shah's talking to the presidential task force. So we're pretty much in sync. We are also in sync with local hospitals. David Entwistle meets weekly with the CEOs of other hospitals remotely. I talk to the CMOs. Governor Newsom himself on Tuesday announced a 6-point plan that he felt was the conditions required for reopening. 4 of those apply to us. One of them is widespread testing availability. Another is identification of potential therapies. Another one is data monitoring so that we know when a surge might be coming in down the road. And the last one is hospital capacity to deal with a surge. So we have independently taken on each of those areas. and are providing data to state and local officials. And that's well within our portfolio and our intentions.
Okay, thank you so much, Norm. So the last question is for me. Emergency medicine physicians have been on the front line for many weeks now. How is morale? I think now in emergency medicine, we've been holding our breath for so long, waiting for the surge to happen. And at this point, we can exhale and then take another deep breath regarding resuming our normal services. Overall, morale is very good. We've got through this as a team, and there's been a lot of team effort in terms of keeping our entire team together and also safe. So we do look forward to getting back to emergencies as normal. Thank you. Alrighty, so thank you so much to our panelists for joining us here today. And also thank you to you, our Stanford community, for tuning into our town hall. Please join us again next week for town hall number Lucky 7. And in the meantime, stay apart, stay vigilant, and stay safe. Thank you.